Let's share this. So hello everyone, I'm your colleague Hamzah from third year. And this lecture, inshallah, will be talking about the autonomic nervous system in the context of your block, CVP. Actually, this lecture is quite interesting as they give you an insight on some neurological concepts in neuroscience, which you will further dive deep in it next year, inshallah. The thing is, like, you don't need to focus about it that much in this block, because if you want to go into details, you will just end up studying the central nervous system anatomy. But this lecture is based on your curriculum, on Dr. Shahid's lecture. Yet, of course, it does not replace his lecture, and eventually the questions will be written by him from his PowerPoint. Another note is that Dr. Atif insisted on us that we go through angina and the referred pain idea. So we will go through that, inshallah. If you have any question, you can just unmute and ask me at any time. Let's start it. So we'll be going through basic principles of the preganglionic and what is ganglia and the postganglionic neurons, the basic sympathetic, parasympathetic, and parts of the nervous system, the heart nerve supply, and definitely the angina. I would like to start it out by reminding ourselves of parts of the peripheral nervous system. As we know, we have the somatic system, which is basically the things that we control. You know, like when I want to hold this thing, I will just send signals to my hand to pick it up and hold it. Where the autonomic nervous system is the part that we cannot control, our internal organs functions. And our autonomic nervous system has two divisions, the sympathetic and parasympathetic. You can remember it by the drawing of this lady. She was camping, chilling, and suddenly saw a bear. And you know, when you see a bear in a jungle, you would either want to fight it or run away from it. I believe running away is smarter. You can remember that by sympathetic, starting with S, symboling stress. On the parasympathetic division, you can see this guy who just ate a lot of desserts and now he's just chilling and he's not in stress, he just wants to digest it. That's why we call it rest and digest. You can remember that by parasympathetic, P standing for peace. The situation is actually peaceful. Now, our internal organs are actually in a balance between the sympathetic system and the parasympathetic system. But then a really important point is that what makes a sympathetic signal sympathetic and a parasympathetic like parasympathetic? The thing behind that is the type of neurotransmitters that the nerves will release. In the sympathetic nervous system, the nerves will be releasing what is called as norepinephrine, where parasympathetic, it will be releasing acetylcholine. Now here we need to focus on a really important point, that based on the type of the receptor in the tissue, the reaction to this neurotransmitter will change. We will get into it in a minute. Here we see a lovely schedule of different organs. We'll be focusing on the CVP. Starting with the blood vessels, sympathetic nerve system has two effects on the blood vessels. If the blood vessels have the alpha-1 receptors, it will cause vasoconstriction, just like in skin and the GI system, where if it has the beta-2 receptor, it will react to the norepinephrine by vasodilation. Just remember our girl who just saw a bear. She wants to run away, so she needs more blood in the muscles, but she does not care about the intestine, about digesting, because as we remember, the parasympathetic is the rest and digest. So we will have vasoconstriction in the skin and the intestine. Parasympathetically on the blood vessels actually does not have a direct effect on it. But we have like these two exceptions. Number one, that we have the M3 muscarinic 3 receptors in the deep arteries of the penis. So in the activation of parasympathetic nervous system, we will have vasodilation causing erection. And generally, the parasympathetic system will have this indirect effect by suppressing the sympathetic system. So the acetylcholine does not actually affect the vessels, rather than actually the parasympathetic activation will suppress the sympathetic, causing an opposite effect. On the heart, beta 1 will cause increased heart rate, contractility, conduction velocity. On the other hand, M2, muscarinic 2 receptors, will cause exactly the opposite: decreased heart rate, decreased contractility, and decreased conduction velocity. In the lungs, similar story keeps going on. We have the beta 2 receptors, and remember, someone who is running away from a bear wants more oxygen in. So we will have the beta 2 reaction of bronchodilation, which means the airway is being dilated to let more oxygen in. M3 receptor will have bronchoconstriction because we don't actually need that much of oxygen inside. Now I want to ask you a question. Can we give asthma patients beta blockers? Whoever wants to answer, please, if you can unmute yourself, because I can't see the chat for whatever reason. Okay. So actually, by the function of the beta 2 receptors, bronchodilation, and the fact that asthma is a disease of bronchoconstriction, and we are having decreased airflow into the lungs, giving a beta blocker is like a big standard red no for asthma patients. We never give that. Even selective beta blockers, you will hear about beta 1 selective beta blockers. Even if they are selective, they are not 100% selective. So their selectivity, okay, now I can see the chat, perfect. Thank you, Idris. So as we say, even the selectivity of the beta 1 receptor is actually not 100% selective, so we will still have this effect on beta 2, which will cause bronchoconstriction. That's why, like in any question, asthma beta blockers, no, never do that. Now here, we want just to understand, in the spinal cord, we have two areas, the white matter and the gray matter. The gray matter, what made it gray is that actually has the nucleus of the nerve cells, where the white matter is just connections. And the gray matter is the area where we have the initiation of signals. The signal starts in the gray matter. What I want you to know from this picture is two things. Number one, the gray matter is divided into smaller areas. We call them nucleus. Each one is responsible for a certain function. We will get some of these functions when we discuss the sympathetic pathway. The second thing that I want you to understand is that the spinal nerve is actually a result of merging between the dorsal root and ventral root. As you can see here, the nerve structure will exit the spinal cord via two pathways, the dorsal root or the ventral root. Then they will join together, creating the spinal nerve. Here, I just want to make sure that you understand these terminology when we say afferent and efferent. Afferent is the direction of bringing signals towards the brain. Efferent is the opposite, taking signals from the brain toward our body. If you want to remember it, it's actually easy. We need to hear before we talk. We need an input before we give an output. And in the English alphabet, A always comes before E. So afferent is the input, the listening, the sensory. Efferent is our output, our reaction to the input. Now, I mentioned to you that we have dorsal root, which means posterior, and ventral root, which means anterior. Actually, afference, or the sensory part, comes always through the dorsal root joining the spinal cord, where the efferent, the let's go, the excited pathway goes from the ventral roots, anterior, or the anterior roots, leaving the spinal cord. Another important definition is when we say a ganglion or a ganglia. All what I need you to know behind this word is that the ganglia is a collection of nerve cell bodies. Their function is to coordinate different pathways together. Now, a ganglia, when we say the word of ganglia, it means the collection of cells in the peripheral nervous system. So not in the brain, not in the spinal cord. But when we have collections of cells in the brain or the spinal cord, we will call it nucleus. So nucleus is exactly the same as ganglion, but ganglion is in the periphery, nucleus is in the central, which is the brain and spinal cord, and brain stem, of course. Okay, tamam. Here we have this beautiful diagram describing the nerve supply of each system. We will start by the somatic nervous system. The somatic nerves will leave the CNS, the central nerve, going all the way to the target tissue and eventually releasing acetylcholine. And you can see on this diagram these lovely blue bubbles indicating that this nerve is actually myelinated. When we go to the autonomic nervous system, we see our friendly ganglion. Remember that ganglions are actually affecting only the autonomic part, where the somatic nervous system does not have a ganglion, just straightforward CNS target acetylcholine. Now, let's dive into the sympathetic division. First of all, we will have a nerve going out of the central nervous system, reaching a ganglia, then from the ganglia to the target tissue. From this structure, we have what is called as preganglionic and postganglionic nerve. So here, this short area with the lovely blue myelinated bubbles, it is the preganglionic. We have then the ganglion, then the postganglionic nerve. And you can see that we don't have here our lovely blue bubbles because postganglionic nerves are actually not myelinated. We here need to notice something, that yet the end product of sympathetic division is norepinephrine, but the communication in sympathetic ganglions is by acetylcholine. But don't mix it with the parasympathetic. So sympathetic, acetylcholine in the ganglion, but norepinephrine at the end of the story. The parasympathetic division, following a similar fashion, going with the preganglionic nerve with our lovely blue bubbles myelinated, but here we release acetylcholine at both the target tissue and the ganglia itself. The same thing goes, postganglionic is not non-myelinated. Here we can notice an important difference between the sympathetic division and the parasympathetic division, is that in the parasympathetic division, the preganglionic nerve is longer than the postganglionic nerve. Actually, the parasympathetic ganglion in lots of the organs are located in the wall of the organ. Where in the sympathetic division, the preganglionic nerve is shorter than the postganglionic nerve, as the sympathetic ganglions are located just beside the spinal cord, which we will discuss in a minute. Now, something copied from your lecture exactly, saying that somatic and autonomic have only one sensory neuron, which is correct. In the sensory pathway, we don't have preganglionic and postganglionic. But something, just for your information, the sensory pathway will go through what's called dorsal root ganglia. We say sensory will join the spinal cord via the dorsal roots. So we have a ganglia there called the dorsal root ganglia. Yet it does not follow the same pattern of pre and postganglionic, but just something for you to know. Does anyone have any questions before we move on? Because now we covered the major structures of the autonomic nervous system. If you have any questions, you can unmute yourself or write it down in the chat. All clear. Perfect. Anyone else? Okay. So let's move on. In this lovely picture, we see that we brought all the ideas together into one diagram. Here we have our sensory information coming from the skin, going to the dorsal root, as I mentioned, dorsal root ganglion, then to the spinal cord. We have our somatic supply going through the ventral root to the target tissue. On the other hand, we have the sympathetic supply leaving the ventral root, joining the spinal cord, then leaving it to go to the ganglion, the sympathetic ganglion, then reaching the target tissue. On the right image, we are just repeating it in another fashion. Also, here we can see the sympathetic, parasympathetic, sensory, and somatic. Now, when we want to talk about the sympathetic pathway, we need to realize a really important structure called the sympathetic ganglions or the ganglion chain. As I mentioned to you, the sympathetic system has shorter preganglionic than the postganglionic, which means the ganglia is closer to the spinal cord rather than to the target tissue. That's because we have a structure present bilaterally on both sides, lateral to the spinal cord, ventral to it, anterior to it, which is called the sympathetic ganglion chain. It's a chain of ganglions specific only for the sympathetic system. And here the story begins. We start from the lateral horn of the gray matter. As I told you, the gray matter has areas. The sympathetic starts from the lateral horn, going to the sympathetic chain ganglion, then leaving the sympathetic chain, going all the way to the target tissue, releasing norepinephrine and having the sympathetic effects that we've talked about. Now, parasympathetically, there is something special about it, that the parasympathetic supply leaves our central nervous system. And as I mentioned, central nervous system means the brain and the spinal cord from two areas, from the brain stem up there and from the spinal cord sacral portion, basically at the end of the CNS. The brainstem supply will give the parasympathetic signals to all of our body, trunk, face, head, heart, lungs, where the sacral part, the end of the story, will supply the end of the story of our systems, the terminal GI tract, and the pelvic viscera. Here on the image, we can see that the postganglionic, indicated in red, is actually way shorter than the preganglionic parasympathetic chain, nerve. Because of the idea that the parasympathetic ganglions are located either in the wall of the target organ or just before it. Now, let's just have a recap on the effects of both sympathetic and parasympathetic on our systems. Blood vessels causing vasoconstriction in the skin and intestine, vasodilation in the skeletal muscles. On the parasympathetic, we have vasodilation in M3 and the indirect effect. Heart, sympathetically working on the beta-1, having the typical presentation of increased heart rate, increased contractility and conduction velocity. The M2 doing exactly the opposite, decreasing the heart rate, contractility, conduction velocity. And with the lungs, we have the beta-2 activation causing bronchodilation, and 3 activation by the parasympathetic causing bronchoconstriction. We go and repeat the note. We don't give beta blocker for asthma patients because they are already having bronchoconstriction. If we even block the beta receptors, there is no bronchodilation signals at all. They will be having a bad time with it. Now, regarding our heart is like any other organ, has its sympathetic and parasympathetic supply. But the heart itself has its own, let's call it mini nervous system, its own circular activation of signals. Because in our heart, we have what is called as SA nodes and AV nodes, sinoatrial and atrioventricular. The SA node playing the major role in setting the rhythm of our heart. So the signal will start from the SA node. Of course, as you can see in the image, the SA node is in the atrium. So that's why we have the atrium contract before the ventricles. Starting from the SA node, atrial contraction, then we go to the AV node. AV node is actually the atrioventricular node. As the name indicates, it sits between the atrium and the ventricle, transmitting the signals from the atriums all the way down to the bundle of His. That's why we have the ventricular contraction after the atrial contraction. Now, a note to have here, in case we are having an SA node, like pathology, SA node disease, whether the SA node is firing too fast, the AV node will inhibit it and will send its own signals. The SA node firing too slow, the AV node will basically start firing by itself. That's why in a lot of diseases, when you read the ECG, you will see the atrial contraction is not related to the ventricular contraction, because basically the AV node is working by itself, split from the SA node. So this could be to many diseases. One of them is heart block, simple heart block, electricity could not pass. Or basically you had the ischemia to the SA node, so the AV node takes over. And in this case, we'll have both atrial and ventricular contraction, but at a different rhythm, different pace. All what I wanted to know that AV nodes sometimes compensate for SA node malfunction. And actually, an interesting fact is that our brain is the inhibitor of our heart. So let's imagine that our heart is just that car driving the steep hill. And if we let it by itself, it will just keep accelerating endlessly. Because our heart, if we cut it off from the brain, it does not have inhibitory mechanism. It's only stimulatory, increasing the heart rhythm, the heart rate. And our brain is actually the driver of this car, having two pedals, the gas being the sympathetic and the brakes being the parasympathetic. But the main function of our brain is actually inhibitory on our heart. So our heart needs more inhibition rather than actually stimulation, because it's stimulated by itself, it's driving down this cliff by itself, and our brain is inhibiting it. But actually our brain is sort of dumb driver. They need to keep both feet on both pedals. So our brain is always sending both sympathetic and parasympathetic, but mainly parasympathetic. Focus on mainly, not only, because sometimes our brain would decide to push on more sympathetic supply to the heart, of course, increasing the heart rate. Here we have a chat. Okay. Now, an idea that your doctors focused on, that we have what is called as the cardiac plexus. And actually, it's a really simple idea. It's basically an area of the heart where we have joining of the nerve supply. Of course, something I might have forgot to mention, that the parasympathetic supply is done by the vagal nerve. So we will have both left and right vagal nerves joining in the cardiac plexus. And we'll have the sympathetic supply also joining in the cardiac plexus. Something mentioned in your lab is that the cardiac plexus is split into two parts, superficial cardiac plexus and deep cardiac plexus. The superficial cardiac plexus is just below the arch of aorta and in front of the pulmonary artery, where the deep one is actually behind the aorta. It's between the aorta and the trachea, so it's in front of the tracheal bifurcation, and it is above the division of the pulmonary trunk. Honestly, best way to memorize this is to visualize it through your lab dissection sessions. Remember what you memorize right now and go there and see it, definitely for your OSPE. Does anyone have any questions for the past sessions? You can unmute or send it via chat. Okay, clear, perfecto. Nice. So now we'll keep going. I think here we have 16 people attending. Yes, 3, 6, 18, 3 pages. Okay. Now let's move forward. And a really important, topic to understand is how our brain understands the sensory signals. We have this mechanical receptors on our skin, sensing mechanical pressure, sensing temperature, and basically all these sensory inputs. Then the nerves will take these signals and send it to our brain. Now, our brain divides our skin into what's called as dermatomes. Dermatomes are areas of the skin in which sensory nerves drives from a single spinal nerve root. So for an example in this image, when we say this is the T1 dermatome, it means that all the sensory information from this area will be sent to the spinal nerve of T1. The same thing going with C3, L2, S1. That's the idea behind it. And actually, when we want to test spinal cord injury, we will be testing the sensation in certain dermatomes to check if like T10 nerve is damaged or not. We will be checking the sensation around the umbilicus button and so on. Honestly, in this dermatome, you need to remember two things. Nipples at the level of T4, the umbilicals at the level of T10. Now, that's for skin, but for our internal organs, how it works is different. Because our brain sensation is based on dermatomes, so it could not actually sense internal organs. Instead, we have in each organ sensory fibers, sensory nerves. These fibers and nerves will join the brain at a certain level of the spinal cord. So wherever they join, the pain will be felt in that dermatome. Let me explain it one more time. So in our heart, we have sensory nerves. In case of MI, we'll be having ischemia, which will cause release of toxins of the cells because cells are dying. And of these toxins, we have pain mediators like lactic acid, mainly in our case here, lactic acid. These lactic acids will be felt by the sensory nerves of the heart. Then these sensory nerves will join the spinal cord at the level of T1 to T4. So our brain will feel it in the dermatome of T1 to T4. That's the whole idea behind referred pain. Or let's just give another example. I have here another image. So if we have something wrong going with the stomach, it will release toxins, pain mediators. It will be felt in the sensory nerves, and the sensory nerves will join the spinal cord at the level of T6 to T7. And our brain will be just, okay, I'm receiving pain signals from level T6, T7. We will realize pain at dermatomes T6 and T7. That's like the whole idea behind angina and behind referred pain. And as here mentioned in the slide, that's what we mean by referred pain at a location other than that of the causative stimulus. So because we cannot feel our internal organs, it will be felt in the places other than the causative organ or causative stimulus. So the projection of pain usually goes into certain dermatome or myotome of the corresponding segment of the spinal cord. Actually, here I have multiple examples. For example, right shoulder pain with patients in cholecystitis. The same thing, the nerves will join the spinal cord at at certain levels, which will correspond to right shoulder pain dermatomes. Going with the same thing with the Kehoe sign, left shoulder pain related to diaphragmatic irritation. Here you mentioned C4, so we have a problem with the diaphragm, it will be felt in that place. We have then the left-sided chest and arm pain for the MI, periumbilical pain around the umbilical button is basically in early stages of appendicitis. Now we are diving specifically for angina. Angina is a type of chest pain which is caused by reduced blood flow. We say they have reduced blood flow, cells are dying, releasing toxins, or their internal components plus toxins like lactic acid. So, and we say that the nerves, sensory nerves of the heart will join the spinal cord at level of T1 to T4. But here I want you to realize something, that we have some dermatome overlapping, we have some nerve supply overlapping. So it's not like pinpoint accuracy, it is just generalized feeling of pain in these areas. Now, I would like to ask a question. Why do we feel the angina pain specifically on the left side? Who can answer that? You can unmute or write it down in chat. Why do we feel the angina pain Okay, dermatomes, correct. And you can have commonly the LAD artery is affected. Exactly. So here we have like it is due to T1. So the thing is, go back, the T1 spreads between right and left, just like, because the spinal cord itself sends nerves to the right side and to the left side. So the T1 is just a slice, right to left. The thing is, we can give it a simple answer of, okay, the heart is on the left side, so we feel it on the left side. Okay, correct. Or we can go, because the most commonly affected is the LAD artery. And I don't want to dive deep into the blood supply, but the LAD artery, the most commonly affected, is the major blood supply of the left ventricle, where the right ventricle is supplied by the LAD and other arteries. As I remember, also circumflex artery on the right side. But for the left ventricle, the main supply is by the LAD artery. So the main affected ventricle is the left ventricle, having the pain spread to the left side of the body. Now, something here that was mentioned in your lecture, which is actually interesting, that the pain, when it is felt in the heart in an MI, God forbid that you ever experience it or one of your beloved one experience it, but if you ask a MI patient survival, they will mention it something like an elephant stepping on your chest. It is that painful. They will be in severe pain. They will not cry. They will not be even able to talk. You will see them just gasping air, holding their chest and barely whispering, because the pain is very, very severe. Here mentioned in your slide that it can present in different fashions. Okay, let's call it. We have the crushing weight. It might be felt as if something constricting it, or like if there is a needle or a drill getting inside. Different description of a severe pain, mainly on the left side, spreading to mainly left dermatomes, but could also spread, as mentioned in the picture, to your abdomen, to your right, of course, based on the location of the MI, which artery is occluded, and it changes, or it's different between a person to another. Does anyone have any questions? Or is it all clear, inshallah? Thank you. All clear. That's great. That's nice. So thank you all. You're all welcome. So guys, if you have any question regarding this lecture or anything academical and academical, you can just always get in contact with me. That's my email, that's my phone number. You can reach me via WhatsApp or email, and I would be more than happy to help you all. Thank you. I think we can stop the recording, right?